For those patients that have been told at other dentists, you don't have enough bone to do this, you're too old to do this, yes. You say that's easy for you. I'm paraphrasing you slightly, but
yes,
it's what you do.
It's what we do. It's what our kind of specialty of specialties is. Okay, so what happens is, and now you have two jaws. You have your lower jaw and you have your top jaw. Okay, now what most patients don't realize is that the best bone in your mouth is right here, kind of like concrete. Okay,
on the lower.
Lower. Okay, and then as you go through your mouth, the softest bone is back here in the back by your sinuses. So this is hard. This is soft. This is a hinge. So your jaw's closing. So your lower jaw in implants or teeth hitting the top jaw, which is concrete versus balsa wood, we're all built this way, but biomechanically it doesn't set up.
Okay.
So many times patients will have problems with their implants or whichever's been done in the past. Now they come in and they've lost a lot of their upper jawbone and they're just told, listen, you can't do anything about it. Okay, you're stuck with a denture. But a lot of times those dentures are kind of like a hockey puck. They're sliding around because there's no gum or bone to hold on to it. So even the adhesives don't work. Okay, so
if they have no bone, what do you do?
Okay, so the best bone in the mouth is right here.
Yeah.
The second best bone in the mouth is right here. So there's a popular procedure in our field in implant dentistry called a sinus lift. Well, your sinus is a balloon. Okay, so what a lot of doctors will do, they'll raise it up a little bit and add some bone in an implant. That's done hundreds of thousands of times a day all over the world.
Okay.
Well, this bone here, your cheekbone, is just right above where the sinus would be done. So in this bone, this is a no graft, no grafting, but it's like this bone. So when you have this hard, like a rock, cheek, like concrete, it's designed that if you ever got hit this way, it's to protect your eye socket. Okay. So if you have bone here that's very hard and strong, and that hinge is kind of going up, and you got soft bone here, well, now we're going to here to give the hard bone against the hard bone. And it prolongs the life expectancy of the implant in the patient. Because we have a problem in our field. We talked about losing bone and tissue around dental implants and failing cases that happen. Well, so what do we do with patients when there's no other options? We have to have solutions for them. So this is an amazing thing.
And they're called zygoma implants.
Zygomatic implants, yes. We've already got 2 clinical publications.
So you're just attaching them a little bit more to the cheek area.
Yes, everything's under the tissue.
So even if somebody's been wearing a denture 30 years, they're told, you have no bone, you can't do implants. I don't care what anybody says.
Yeah.
You can usually get it done.
Absolutely.
As far as downtime, things like that?
It's the same as the other procedure.
Like 3 days later, you could have your teeth?
Yes.
You do that a lot?
We do that a lot for patients.
Would you say less than 5% of dental implant dentists are doing these special implants?
I think it's probably less than that. I think it's probably 2%.
Okay.
Yes. But, there's been some interesting studies that have been done that have shown the growth of these types of implants over time based on all these things we're discussing. And they're looking for the frequency of these implants to be incorporated, growth spurt over the next 10 years at 20% per annum.
You teach other dentists how to use these special implants?
Yes, we do.
For people without bone?
Yes, we do. We're one of the centers around the world that will take doctors in, didactic portion, and then surgical portion, and we get them through almost a little small mini residency how to do it. Yes. And then a lot of
So nothing to be afraid of if you're a patient? Really?
You need to be able to make sure that the clinician that's doing these procedures for you has adequate training. And I would ask a lot of questions. I would say, tell me how many of these done, show me some cases what's done. And because this is another level of treatment options, much more advanced. And here's where you really need to make sure you're going to the right individuals, right team for that work. But they are successful let's take it back a second.
Okay.
Let's talk about how frequently these should be done. My 100th publication, which is going to be starting next year, we're going to go back 10 years in x-rays of cases completed, upper jaw only, and look at cases that had those 4 implants with the acrylic teeth and why those cases had failed prematurely. A lot of it's because best bone, then here, and this worst bone. Because that back implant just wasn't in the right, that pillar wasn't in the hard enough concrete, okay? And we're going to look at what percentage of those cases should have had the cheekbone implant considered day one. And we have some ideas where it is, but it's going to be in the 15 to 18% range that from day one, those implants should have been considered from the treatment planning process based on the patient's.
So they're slightly longer implants.
Slightly longer. Okay. And they're going to suspend under the tissue, and they're just going to secure in very hard bone instead of in soft bone.
So it's just more technically demanding? Is that why all dentists are doing this?
Correct. It's technically demanding.
But for the patients, the same downtime and everything else.
Same downtime, yes. And I actually pioneered a procedure where we do it now where most dentists can do this. Instead of being a little more invasive in this region, we come back here a little more, and it's much more minimally invasive and less traumatic to get to, and it makes use of this bone as much. And we're writing another paper on that. But it's hard to read all the papers.
People travel to see you. Is that true? I mean, they're from out of state all the time.
We've had people from around the world come in. I've had people from... I had a young lady, because I do a lot in South America. So we had actually a dentist in South America, in Medellin, Colombia, flew in for me to do her left central incisor, because she was a beautiful girl, high lip line, and because I won't have anybody but you. And then she had sent me another beautiful young woman that was getting married, and I did her right when she needed to have done. And then I had a patient come from China that flew in, had the surgery done, went back to China, okay, came back 7 days later, just with travel, and had his other one done, and came back. So I've had them come from all over.
So they could fly in on a Sunday, see you on a Monday, get a brand new set of teeth on a Wednesday.
Yes. The best way to do it is you come in on a Thursday.
Okay, Thursday.
Okay, and then we put you in a hotel. We have packages for that, and then Monday morning you get your teeth. I check you Tuesday, you go back. This way I have enough time to make sure everything is good, especially because you're not getting in the car and driving to the other side of Chicago. We had a young lady fly in from Seattle. Her dentist heard me talk about zirconia implants. Holistic girl, she only wanted zirconia. Nice, beautiful smile, high lip line, so you saw everything. And she wanted zirconia. He told her, you got to go see Paul.
Which is a metal-free implant.
Metal-free implant.
Okay.
She came in, and we did the implant for her. She stayed 2 days. She went back, and she's just now, we got the x-rays from him. She's ready to have the final crown done by the dentist. But she had her tooth all the time. She had a temporary in there all the time. Yeah, this is what we do. This is our reputation. But we pride ourselves on being able to be as minimally invasive as possible, even though we're talking about some other types of procedures, and as conservative as possible, but also delivering the highest level as possible with what can be done. And that girl came in, she had no stitches, no incisions. Now there's times we have to do that stuff, but generally, if you can follow the procedure that I was one of the pioneers of, you can have this done and never miss a beat. Never.